This is CCTA case number 22. The history is that of an 80-year-old man with shortness of breath and an abnormal stress test. There are 3 phases for review of the coronary arteries. Those can be changed by either going to the next or the previous button until we get to the phase that we're interested in looking at. This particular type of case is certainly not atypical. This is a suboptimal examination. There are clearly motion artifacts, but you need to take each of these segments individually. The real value of the test is to define whether or not this patient has any existing atherosclerotic disease, and then to determine its extent, and then finally to determine what should be done about the patient. So let's begin here. There's clearly some plaque involving the proximal portion of the aorta. We get into the left main area. Let's take a look at that a little bit better. It's a little bit of a motion. Let's see if another phase would be just a little bit more helpful, at least evaluating the left main. I would say the left main is normal. There may be some mild eccentric non-obstructive plaque. Let's start looking now, going to the foot view. Let's start looking at the left anterior descending. There clearly again is some mixed plaque in this area. The very proximal portion is non-obstructive. Immediately beyond that, though, switching to the foot view, we can see that there is a focal area, what appears to be largely non-calcified plaque that appears to be obstructing, or it could even be subtotal. Let's see if another phase will help us get a little better characterization of that area. Doesn't resolve it very well. There clearly is obstructive non-calcified plaque involving the proximal mid portion of the left anterior descending. There's clearly extensive plaque beyond that. As to whether or not that's obstructive or not is unclear. You can see that the LAD does continue all the way down to the apex, so it is clearly a patent vessel, which is important for overall evaluation of this patient. But we've already established that he has severe proximal mid obstructive left anterior disease. Let's take a look at the circumflex vessel. Again, very difficult to read, motion artifacts, lots of calcium. Changing phases may or may not be helpful. It's unclear, but as we look at this proximal portion of the circumflex, it becomes very difficult to interpret. If we switch to an MPR view, you can see that right at the juncture of the obtuse marginal and the circumflex, there appears to be clearly focal obstructive disease. So again, we've now found, so switch back to the 5mm MIP, we found a disease of obstructive nature involving both the LAD and now a portion of the left circumflex. Let's look at the right coronary. Proximal appears to be relatively normal. Let's focus on this as we try to rotate around. As you can see here, there's a flush occlusion in the proximal portion of the right coronary artery. This is non-calcified plaque, thrombus, all the way down to the distal distribution. Now, there is clearly flow in the distal portions of the vessel, although there may still be some focal obstructive disease right at the distal portion of the distal right coronary artery. There is clearly flow involving the posterior descending. Given the fact that this patient has clearly occlusive disease of the proximal portion of the right coronary, this is consistent with collateral flow. So regardless of the fact that this is a very difficult study to read, you need to focus on the main picture here. This patient has significant advanced triple vessel obstructive occlusive disease and needs to go on for further evaluation, including cardiac catheterization, to better map out these areas, and then an intervention. Likely, given the extent of disease, this patient would be probably a better candidate to have coronary artery bypass grafting.